Hello. Happy VMR, Friday VMR. Everybody, welcome. I think probably say this almost every time, but we have a very, very special VMR today for really two reasons. But I will spontaneously pass the mic to our beloved team member, Jas, to tell you the core initial special reason and then tell you more in a second. So Jas, what's so special about today, my friend?
I think every VMR is special, like you said, but today we are grateful to actually have, well, first of all, we're grateful that both you and Reza and the entire CPS team agreed to come back to the University of Rochester for another case discussion. I believe this is the third time. So 2 years ago with Brendan Robinson, last year, and then again this year. So we are really grateful. But it makes it extra special because today we have Dr. Sarah Lichtenstein, who is a second-year family medicine resident, who will be presenting a fantastic case that she saw during inpatient medicine. So when she presented it to us, I was blown away by the case, and I felt like this would be a great CPS solving case. And then if you're all okay with it, I'm going to quickly introduce Sarah. So Sarah is originally born and raised in Baltimore. She then went to Wake Forest School of Medicine for her MD, and she's a huge Baltimore Oriole fan. And not only is she kind and intelligent and a rock star of a resident, but on top of that, she's one of the co-champions of the wellness team at our program, as actually have implemented and advocated a lot of positive changes for the program. So really honored to present her or introduce her today. And I'm going to stop talking because the floor is between you three now. So
amazing. Sarah, it's so nice to meet you. I clearly somebody we admire and respect views you in such positivity. Welcome. It's so nice to meet you.
Thank you. Happy to be here.
I also see that Reza is here. Prof. Rez, hello.
Good morning, Uncle Robbie. Does everyone know Robbie's amazing news? Yeah, okay. That's when you show up late, you don't know what the people know. So I'm going to refer to you here on out, Uncle Robbie.
Well, I shared the news with the CP Solvers team, but the reason my whole family is in the car right now is we're headed, we're a 1 hour drive, conveniently 1 hour drive away from my newborn baby nephew, Anthony. My sister delivered, and we're on our way to meet him, and really, really excited, and very excited that my wife offered to drive. And I was just telling the team that it's been a very smooth, seamless drive, but only after the first 3 minutes where we almost run over two separate people.
Hey, Kara, eye on the road.
So we're cruising now, and very, very excited for hanging out with Jas, Sarah, and you, Prof. Rez. So Sarah, kick us off, please.
Sure. So just to begin, this will be 6 aliquots. And I'm so excited to share this case with y'all. So we're going to start with the first aliquot. We have a 40-year-old male presenting to the ED with 1 month of progressive cough, shortness of breath, and hemoptysis. Just a little bit of backstory. He presented to a neighboring hospital in July of 2022 for a 2-month history of intermittent chest pain with associated blood-tinged cough and pain that radiated to his back. He had a chest x-ray that showed a right middle lobe opacity with a small effusion. He was then discharged home with a 7-day course of cefuroxime and doxycycline. He then presented to the neighboring hospital a few weeks later, this is in August of 2022, with no improvement in cough or pain. They repeated a chest x-ray that showed no changes. They did a CT of his chest that showed scattered pulmonary nodules. They then prescribed him a 5-day course of azithro and discharged to follow up with his PCP. He had no improvements, which prompted him to come to our hospital emergency room. So when we meet him, he's reporting ongoing cough, worsening dyspnea, pleuritic right-sided lateral chest wall pain when coughing or breathing deeply. He's also endorsing severe right upper and lower back pain. He reports fever, cough, hemoptysis, shortness of breath, and chest pain. He denies any history of pneumonia in the past. Weight loss, however, some people have been telling him that he might have lost weight. Prior thoracic surgeries, leg pain or swelling, recent prolonged travel, or history of blood clots. He has no sick contacts, international travel, animal exposure, specifically to birds, chicken, livestock, and outdoor hobbies, including hunting, fishing, hiking, and gardening. For his medical history, he is a former smoker. However, he quit 1 month ago. He had a stab wound in 2010 to his back. His history of a right knee patellar tendinitis. He was incarcerated in 2010, and he's had no regular primary care. He denies any surgical history. His family history is notable for his mother, who is deceased from stomach cancer, his aunt, who has a history of breast cancer. For his social history, he was born in Rochester, New York, only traveled to Niagara Falls. He's a manager at Wendy's. However, he's previously worked in construction. For tobacco use, I already mentioned that he quit 1 month ago. However, he intermittently smokes cigars. For alcohol use, he has about 2 to 3 drinks weekly. Sexual activity, only 1 female partner with no history of prior STIs, and he has 2 children. He's not currently on any medications. This is the end of aliquot 1. If you would like me to go back and share information if I was going too fast, I'm happy to go back and give any part of the history.
Let's hear some math. Uncle Rob.
Oh, you're making me blush. Sarah, that was a incredibly rich aliquot. And I'll share my sentiment going through it is I felt really overwhelmed by the data. And I think I'm saying that out loud because it really represents a reality in taking care of a patient like this when, gosh, I remember the feeling as a resident when you would have a transfer from another facility and then the stack of paper would show up. And I would just really dislike the next 2 or 3 hours because I never felt like I was standing on solid ground. I felt like I was standing on an extremely wobbly surface and wouldn't at all feel like I had my feet. And I really want to take a second just to commend the incredible effort by Amanda to keep up with you. And I know Yaz seems to be jumping in there too to like get all this data down. That was awesome work, team. Really appreciate you all. And awesome work to you, Sarah, for being able to crystallize this data so clearly for us, because I imagine the person who was actually taking care of this patient, possibly you, was probably way more overwhelmed than I am right now. And I think my only task here now is to pass the mic to Prof. Rez to dissect the syndrome further, but tell you how I try to tackle the sense of being overwhelmed. And I think embedded in any kind of hardship, including some simple hardships like overwhelmed with data, is a lot of learning. And for me, over the years, I've learned to really pay attention to what I think amongst all this data is the most profoundly helpful and what is relative noise. I say relative noise because with more time to process and more information, things that were previously thought to be noise may have all of a sudden become very, very powerful. But so far, here's what I grasp. Hemoptysis is something never to be ignored as it represents an abnormal connection between the vessel and the airway. That's never something to be ignored. And that to me was said so many times that it stuck. It also stuck with me that this syndrome has evaded diagnosis for some time, over a month, so subacute. So I was like, okay, this is a subacute hemoptysis syndrome. And then I heard the word CT chest. That data point is going to be more powerful than any other data point in a hemoptysis case, because it allows us to study what the nature of the connection between the airway and the vasculature is. But truth be told, I was trying to process the data and I don't remember what the results of the CT chest were. So Sarah, I'll just pause to ask you to remind me what that initial CT chest might have showed.
So at the outside hospital, the CT of the chest showed scattered pulmonary nodules. And since it was at an outside hospital, we didn't have the
Understood.
images that we were able to look at.
Oh gosh, yeah, I mean, just another level of like, it shows maybe possibly scattered pulmonary nodules because we haven't seen it. I think that's the reality that we're in. So I will just say that what stuck with me is a subacute respiratory syndrome characterized by hemoptysis with a working radiographic signature of this disease, a working one of a nodular-based disease. So I think it's tempting to then study what the nodules might represent. And I'll pass the mic to Prof. Rez to reflect on where he's at and what he might think of that. I will say, I'm also very glad to hear of all the other things that the CT chest did not show. So what else could it have showed? It could have showed primary vascular issues, like a pulmonary artery embolus, for example. It could have showed cavitary lesions. It could have showed bronchiectasis. So not only do we have a lead to follow with nodules, it's also awesome that we have made other common causes of hemoptysis, including PE and cavitary lesions, less likely. All right, Prof. Rez, I'll pass the mic to you.
Hi, Sarah. It's nice to meet you virtually. And Robbie, thank you for teaching that, how to deal with that sense of feeling overwhelmed. And I really loved what you did, because when I was tracking this case, I was like, okay, cough, non-specific. As soon as shortness of breath came, I was like, all right, I'm going to tackle the shortness of breath. But then we got hemoptysis. I was like, forget shortness of breath. That can be due to heart, pulmonary, and so many various causes. I'm going to focus on the hemoptysis. Then we got the nodule. I was like, forget the hemoptysis. I'm going to just focus on these scattered pulmonary nodules. Literally, that's what my thought process went through. And with pulmonary nodules, which is really the center of gravity and the focus of this case, it's nice to characterize them. And Sarah did that for us. You can have different distributions, like centrilobular pulmonary nodules, which may occur with aspiration. You can have perilymphatic, which may occur in the context of sarcoidosis, or you can have scattered pulmonary nodules, which is what we're contending with here. When you have scattered pulmonary nodules, it usually suggests some form of hematogenous spread of infection or cancer. These are the two priorities in this case. We can consider the third bucket of autoimmune disease, but just based on what we have right now, it takes a back seat to hematogenous infection and cancer. And now that we're even bringing up infections, the types of infections are the ones you expect to have a subacute tempo. And because we're thinking infections in the lung, and we're thinking of subacute tempo, right away we want to know the immune status of this host. What is their HIV status? And do we have to broaden that infectious CDX to include opportunistic infections? And Robbie, something I learned recently, and it was like an aha moment for me, is that we had a patient who had a subacute tempo of disease, and we were most worried for infection. And I erroneously kept saying atypical, atypical. When I say atypical, we're talking about stuff like fungal, TB, those infections that have an indolent course. But in that case, it ended up being staph in the bone. So right now for me, when I think of subacute, it's not only those atypical organisms, but it's common organisms that are contained within a specific area that is hidden from the body. But in this case, it's not hidden. It's obvious. It's in the lungs. So the top infections to consider are tuberculosis, and its cousins, which are all sorts of fungal infections, specifically the endemic mycoses. Because think about it, if this disease have left its footprint in the lung, how does it get to the lung? Likely through inhalation of some sort. So the immune status is going to be important, but cancer, whether it's lymphoma or solid cancer that has spread to the lung, is another possibility. And then finally, if you were to invoke an autoimmune process that may have nodules in it, microscopic polyangiitis can give you a nodular pattern and can cause a vasculitis. But right now, I'm inclined to think the nodules itself are enough to explain the hemoptysis, so we haven't quantified the hemoptysis. And therefore, I'm looking more for a hematogenous infection or malignancy. That would be my leading hypothesis. And since this data was so rich, Robbie, I would just love for you to comment on any other thoughts or additional layers to add there.
Oh, I think that's absolutely superb, Prof. Rez. And in this world, I would make the argument that the law of proportionality is going to help us tremendously, because we're making the argument that this disease is spreading hematogenously to the lungs. And so if there is an infectious process disseminating in this manner so aggressively to the lungs, I think it's fair to expect a very prominent, severe systemic fingerprint of that same infection. So to be concrete, if this is miliary tuberculosis because of incarceration in 2010, and if it is affecting the lungs in a hematogenous way, we expect a proportional evidence of injury to other organs. And so it'll be really interesting to see, is this hematogenous disease that is proportionally affecting the whole body? Or is this hematogenous disease with a tremendous propensity for the lungs, a magnetic attraction to the lungs? And I think that's the kind of problem solving that my mind is ready for now, is what is the lab and the exam going to be like? And are we going to end up calling this hematogenous but lung disproportional, or hematogenous but lung just being the tip of the iceberg? And that, I think, will be a very helpful way to sort through the analysis that you just gave us. All right, Sarah, tell us more, please.
All right, so we'll begin our second aliquot. For vital signs, his blood pressure was 130/90. He wasn't tachypnic. He was afebrile. He was satting 98% on room air, and his heart rate was 98. He was describing 10 out of 10 back pain, or pain that was localized to his chest and his back. For his physical exam, he was in no acute distress. He was non-toxic appearing. He was uncomfortable when moving due to pain in his back. Heart rate was regular rate and rhythm, no murmurs, rubs, or gallops, and his cap refill was less than 2 seconds. For his pulm exam, he was diminished in the right lower lung fields with fine crackles, and he was coughing frequently with deep inspiration, as well as splinting the right side of his chest wall. Abdominal exam was unremarkable. For MSK, he did have tenderness to the upper thoracic spine along the spinous process, with no edema or tenderness in his bilateral lower extremities. Neurologically, he was ANO ×3 with no focal deficits. For lab work, he had a white count of 13.6 with a left shift. His hemoglobin, 12.7. Platelets, 490. His PT was 16.9. INR, 1.5. And his protein was mildly elevated at 8.8. The further labs that we obtained was an iron level that was low at 18, transferrin low at 166, a TIBC of 224, ferritin 470, which was elevated, and he had an EKG that was normal. So we ordered a chest X-ray, and a CTA. So with the chest X-ray, that showed a right middle lobe collapse, as well as a right pleural effusion and consolidation. Jazz is now going to share the image of the CTA, and then I can go into those findings. So for the CTA, there was no evidence of a central pulmonary embolus. It showed right perihilar consolidation that was extending into the right lower lobe with near complete collapse of the right middle lobe. There was also multiple obstructed bronchi. There was also a low attenuation material along the right aspect of the T5 vertebral body with bony destruction of the adjacent T5 vertebral body and the posterior fifth rib. There was also ground glass attenuation throughout both lungs. This is before we admitted him. He was started on vancomycin. We sent a MRSA swab, collected blood cultures, contacted IR for a right thora, and he was admitted to the floor. And that concludes our second aliquot.
Wow. Sarah, thank you for showing us the images. And more importantly, thank you for giving us the impression of those images. What I'll do is I'm going to tackle the labs and leave the physical exam and the CT scan for Robbie to comment on. And right away, one of the things I love doing is looking at every lab and trying to explain why it exists. And I encourage each of you to do this as well. It is true that sometimes it's not relevant or it's not, an important theme to the case, but it's such a great mental exercise. And by doing it when it is important, it will pay off. So we can start with 1 second, folks. I like to look at Robbie and I lost my screen when I talk. Okay, there you are, my friend. We'll start with the CBC and we'll just go in order and we'll interpret everything. The leukocytosis, I don't think any of us are surprised by. This patient is stressed. We're getting a clinical flavor for inflammation. And then we look at the platelet count, and that is consistent with this subacute inflammatory process. The platelet count being elevated like that would be consistent with an atypical infection. So far, that CBC, the anemia, the thrombocytosis, the leukocytosis is all suggesting underlying subacute inflammation, which we picked up from the tempo of the disease. Then we come down to the chemistry panel. And here you have to be always a little cautious when you're looking at the creatinine, because the creatinine is based on the muscle mass of the patient. This is a young patient, so I'm inclined to think that creatinine is suggestive of normal kidney function as opposed to an older individual. The iron panel is really interesting. You see, in order to transcribe the ferritin mRNA, your cells need to be iron replete. But there's really two important parameters to analyze when you're trying to determine if you're dealing with iron deficiency anemia or anemia of chronic disease. One is the ferritin. This ferritin north of 200 is highly suggestive of inflammation. It's diagnostic of inflammation. So this patient does have a component of anemia of chronic disease. But to determine if there's concomitant iron deficiency anemia, you take the iron, you divide it by the TIBC, and you multiply that by 100. And Robbie, what does that equate to? I'm just joking. So I use the calculator. It's around 8%. And that is suggestive of iron deficiency. So I think there is a component, despite the ferritin being so high, but the ferritin, the platelet count, the white count, the anemia, all consistent with inflammation. which usually means infection, cancer, autoimmune process. The INR of 1.9 is intriguing right away. You wonder, is something going on with the liver? But then the platelet count sort of shoots that hypothesis out the window. Then you worry about just the nutritional status. So this is a patient I would give vitamin K2 to see what happens to that INR. I'm less inclined to think it's factor 7 deficiency, but it's not enough for me. But I go through that DDX, but it's not enough for me to send all the studies just yet. I think I got to the end of the lab, so I'm going to pass the mic to Robbie.
Rafael, I love that. I panicked when you asked me to do that because I was tossing and tossing and tossing. I think that you're right. Like the labs here are kind of reinforcing what we already know, and I think that physical exam did the exact same thing for me. I wasn't too surprised, but isn't it crazy the massive pivot on the imaging? There's no nodules at all in this image at all, right? And so I'm just like, I'm really, really having a hard time putting this together. And then ultimately, I'm a little bit tense because I'm going back to a very basic principle, which is that when things spread, they spread in two fundamental manners. They spread through the vasculature, either hematogenously or through the lymphatics, or through a contiguous extension. So we talk about this a lot. The patient has osteomyelitis. That the osteo, was it hematogenous or was it through contiguous spread? And I was having some struggles because my immediate reflex was whatever this process is, be it infection or cancer, immediately my reflex was it's spreading hematogenously because there's distant bony involvement. But then I started to look at the read more closely and was like, wait, the right middle lobe is collapsed. There's an effusion associated with that collapse. And then the rib next to that is destroyed, and the vertebral body next to that is destroyed. Is this a case of pseudo-hematogenous spread? And in fact, we're having a process that's not going like this, but rather like this. And that, I think, will really change how we think about this case. For example, a classic presentation of a somewhat rare disease, actinomycosis, would be that it's aspirated in the airways, causes an pneumonia, invades into the pleura, invades into the bones, and does not spread hematogenously. That would be a very unusual presentation of TB or endemic mycoses, which spread hematogenously. So at the end of the day, this is why we have to talk to radiology, because I'm never going to be confident about saying, can I put an arrow between all the findings in one straight line? Or does this radiographic imprint of a widespread hematogenous dissemination? And I think for me, instead of spending time about what infectious this could be or what cancer this could be, I think in real life, I would be trying to understand what the real problem is. And we've made progress by saying this is a lung, pleural, and bony problem. We have not yet studied the abdomen. And the question is, are they connected by Cupid's arrow or the opposite? Or are they connected by a vascular imprint? And I don't know the answer to that yet, but I'm really curious to see if that's knowable, you know? But I've talked a lot. I'm curious what other thoughts you have about the imaging, the exam labs, or anything else. There's a lot of data here.
My gosh, I love how you commented on actino and the difference between hematogenous and pseudohematogenous. And I think you'll like this. Rory, you shared an article with me on cavitary lung lesions a few weeks ago. And in that article, I highlighted one phrase, which probably isn't relevant to this case, but I think it's worth mentioning. And that's referred to as phantom infiltrates of coccidiomycosis. And what that is that a patient has a CT scan, they see abnormality, but then the abnormality goes away and shows up in another part of the lung. And then having that idea of phantom infiltrates, I think some malignancies can do that as well. There was something I think in NEJM or Twitter, I don't recall, but it just grabbed my attention. So I'm very curious to know what the prior imaging, if there were nodules, and if we're dealing with phantom nodules and pseudohematogenous process. Oh, okay, back to you, Sarah.
Okay, so now we'll start our third aliquot. So IR obtained our bone biopsy of T5. They also completed our request for a thora. MRSA came back negative, so we discontinued VANC. We had our pleural fluid analysis. The appearance was a hazy yellow. Nucleated cells of 10,250 with 70% lymphocytes, 20% segmented neutrophils, and 10% monocyte/macrophages. RBC count was 6,000 with a glucose of 99, LDH of 350, albumin 3.1, and a protein of 6.4. His serum LDH was 158, and his serum protein was 3.4. He was getting daily labs. His white count stayed stable in the 14s. Hemoglobin was stable in the 11s, and his platelets also stayed in the 400s. He was having increasing pain throughout admission, so we added Dilaudid for breakthrough pain, along with Flexeril and lidocaine patch. We then discontinued his antibiotics, so he had a 1-day history of VANC and 4 days total of Zosyn. 4 days into his admission, he then had left lower extremity pain and swelling, as well as new lumbar back pain. And that concludes our third aliquot.
Sarah, I feel like your presentation skills are just so smooth and polished and crystal clear. And I also appreciate something that you're doing, which is relatively new here, which is being fundamentally clear on what treatments are being offered and given to the patient, because they profoundly influence our thinking in real time. Did the patient get better or worse on VANC? Was their pain controlled on Dilaudid or not? And I think those are very, very new and awesome, very helpful features. And kudos to the scribing team. I have no idea how you're jamming all this information on the whiteboard, but it's happening. Prof. Rez, I'll just analyze the pleural fluid and then maybe kick the rest of it off to you, which is I think that that reflex analysis is used to take advantage of the fact that this is an exudate. So I think it reinforces what you said about the labs, that this is a inflammatory disease process now confirmed to be in the pleura. What is more helpful, because it's hard to predict it beforehand, is the diff. So the fact that this is not neutrophilic in nature helps us be confident that this is not a pyogenic bacterial infection, because from the get-go, you told us we have to think just because it's subacute doesn't mean it's not staph hiding in the pleural space. But I think lymphocytic response is more characteristic of intracellular organisms like TB and the endemic mycoses, and is more characteristic of the effects of cancers in the pleural space. So I found that to be helpful in narrowing our DDX more to atypical infections, truly now, and malignancies. I'll pass the mic to you for any other thoughts about that or the rest of the data.
Roy, I'm just thinking about our journey and like learning medicine, how 5 years ago when we were chatting, we probably would have skipped over the lymphocytic predominance of the pleural effusion until we had Zofia. If you remember the case where she taught us the importance of pleuritic chest pain. But medicine is so beautiful. As you like progress, as long as you're deliberate and reflective, you just keep adding on to your knowledge base. And I think what I would do at this juncture, and I'd love to dance with you a little bit. One, the left lower extremity pain and swelling, you got to get a stat ultrasound. Like to me, that's a DVT until proven otherwise, because we do have chronic inflammation in a patient who's hospitalized with hemoptysis. So it's unclear if pharmacologic DVT prophylaxis, thromboprophylaxis was initiated. So I would be evaluating for that. But at this point, I would just be summarizing everything. And the way I would summarize it would be parenchymal consolidation, multivertebral level pathology, a pleural effusion with lymphocytic pleocytosis, and a subacute course. And when you analyze something like that, with the lumbar pain, what I'm thinking is it's vertebral destruction, but you have to make sure that whatever process is happening in the spine isn't causing damage to the actual spinal cord, because then all of a sudden you're dealing with a neurosurgical emergency. And now I think we can confidently say this is not autoimmune, and it's either infection or cancer. And if it is cancer, because of the lymphocytic pleocyte, I would prioritize lymphoma, but then the platelet count makes me think lymphoma is unlikely. So now I'm going away from cancer and really prioritizing infection. And in prioritizing infection, this is where I want to tap into your mind, Robbie, because I know some infections, even the atypical ones, they have a tendency to affect specific parts of the vertebral column. So I was just curious, tapping into my chat GPT or my chat Robbie, which infections, like when you think of that bucket and you may be thinking about something else, like which ones are prioritized? Can we make any progress based on the location?
Prof. Rez, your goal is to make me blush today, Uncle Robbie. Yeah, I think there is some, you can glean some insight. I learned this from Dan Minter. In general, I think TB tends to prefer the thoracic spine, and brucella tends to affect the lumbar spine in terms of those two infections. But actually, I don't really know anything beyond that. And I think that the fact that this seems to be affecting both the thoracic and now potentially the lumbar spine makes me kind of go in a circle. And I'm not sure what I can do with that, because initially just T-spine, which is really interesting, by the way. The reason TB affects the T-spine predominantly is it's really contiguous spread from the lungs. Like it's right from the lungs into the thorax, into the thoracic vertebra. But brucella going to the lumbar spine, I'm not sure. That's a very common dilemma in many parts of the world where TB and brucella are fair game. Prof. Rez, I'm really intrigued. Things here. One is like how quickly this is progressing. Like he was fine and now he has back pain. And that made me think, oh no, this has to be infection, just like Aaron's case of the infection that rapidly took off in the brain. I don't want to keep it blank for people who might listen to it in the future. And he's like, in retrospect, that was rapid development of an inflammatory progression in the hospital is suggestive of infection. But then, presuming this is a DVT pushes the cancer more likely. So here I am spinning in yet another circle, because one thing argues for an infection, the rate of progression of this disease. And the other thing, the presumed DVT, argues for cancer. We all either know or will know in the future that both those things are highly imperfect, but they definitely are tipped one way or the other. So here I am yet in another circle, but I know how we can figure out this problem. This disease, whatever it is coalescing into a specific mass right there in the spine for us. And I think that at the end of the day, we always say tissue is the issue. And unless we get lucky by sampling any bodily fluid, be it the bronch or the pleura or even the sputum, if we get lucky, great. But if we don't, I think the disease is literally saying, hi, I'm right here destroying the thoracic and maybe even lumbar vertebra. Come find me. And I'm sure this incredible team will definitely come find it. Any other thoughts, Prof. Red?
Oh, Robbie, as you were speaking, going back to this whole hematogenous versus contiguous spread, I'm just reminded of Lawrence Tierney, who is Gurpreet Dhaliwal's mentor, LT, and the pearl he shared at one of the morning reports, which was, and I later validated this through actual publication. Not that you need a fact check LT, but I did fact check him. And it's analyzing the intervertebral disc space. You see, the intervertebral disc space is an avascular space. In order for that to show pathology on imaging, you need a process that can just destroy and not require vessels to just go through contiguously and damage that intervertebral disc space. But malignancy, because it relies so much on blood, it actually spares that intervertebral disc space. So I think, now this isn't 100%, but I think we can even make more progress on cancer versus infection by asking the radiologist, what's going on with the intervertebral? Are we having two vertebra and contiguous spread through that intervertebral disc? If so, then infection is prioritized. So I think the lymphocytic predominance in the pleural effusion prioritizes infection, but the DVT is the cancer, as Robbie mentioned, and then the intervertebral disc space will allow us to make even more progress. And yeah, but ultimately, I think you got to image that lumbar spine, probably get a biopsy, because if we are dealing with TB, unless you can get something from the lung and then say it's all spread through that. Very interested to see how this unfolds, Sarah.
All right, so now we'll start our fourth aliquot. So he had bilateral lower extremity Dopplers. Both were negative for a DVT. He was continuing to have low back pain as well as left knee pain. So we ordered a MRI of the lumbar spine as well as a left knee X-ray. His pleural fluid cytology came back. It did not show any malignant tumor cells. However, it did show marked chronic inflammation with increased eosinophils. He fevered overnight, so we decided to consult our ID experts who recommended that we repeat blood cultures, serology, and the TB antigen stimulation test. They also recommended that we send his sputum for aerobic, anaerobic, fungal, and AFB stain and culture. His MRI of his lumbar spine showed edema and enhancement in the left half of the L4 vertebral body. There is cortical breakthrough and an enhancing soft tissue component causing severe left neural foraminal narrowing and posteriorly displacing the left L5 nerve root. Along the L4 osseous lesions, there is enhancement and edema along the medial left psoas muscle. And there is an osseous lesion, right ilium body, that was measuring 1.6 by 2.9 centimeters. And the lesion is a large, central, non-enhancing focus that likely represents necrosis. Jazz is now going to share his screen with the left knee X-ray. And this X-ray showed a low attenuation lesion in the region of the tibial tuberosity. There was no evidence of fracture or dislocation, and there was no joint effusion. If you would like me to go back to any of that information, I can repeat it, but that ends our fourth aliquot.
Sarah, a question for you. Was there any eosinophils in the blood? Was there an eosinophilia or just all pleural effusion?
I didn't document any eosinophils, so I don't think so. I'd have to look back at his chart, but I didn't document that.
I can confirm, Sarah, there was no eosinophilia in the blood.
Okay, I just asked that question because it could help the differential diagnosis somewhat. Though honestly, even without it, the infections we're concerned for, we're still concerned for it, even without the eosinophilia in the blood. I think at this point, this is what concerns me, that this is progressing rapidly. Whenever you see necrosis, it's telling you that you have some kind of destructive process or some form of pathology that's preventing blood from reaching a particular area of tissue. Because necrosis is the end state of ischemia. And Robbie, reflexively, to me, this is some form of invasive infection or cancer, but quite frankly, I'm leaning more towards infection. And I think what we need to do now is to quickly biopsy something to get an answer. Why? Because if we don't, that process may invade the spinal cord. And then all of a sudden we're dealing with a myelopathy and the need to do some kind of neurosurgical intervention. So at the end of the day, we have bone disease, we have lung disease, we have pleural disease, distinguishing that from lung parenchyma. I'm almost inclined to think that the process started in the lung and now has made its way to the bones. And this patient needs to be ruled out for tuberculosis. And that's very important because you have to be concerned about everyone else. And that lymphocytic predominance makes me very, very worried about that. I would also send an LDH for good measures because lymphoma can involve all this, though the platelet count makes that hypothesis a little less likely, but I would send an LDH as another data point. But I'd love to hear where you are. I'm still in like infection, TB, endemic mycosis, and less likely lymphoma or some kind of malignancy.
Alfred, I'm right there with you. I really am. And I think that you ask yourself, like, what is the goal of what we're trying to do now to like get better at understanding the fingerprint of this disease? And I think really there's two parallel things that we should be practicing, which is one, how do we solve the problem? And how do we anticipate what it will show? And I think the real growth for all of us in real life is like, how do you look at this and figure out what's next? Because nobody can tell you the answer right now. And I agree with you. I think you need tissue. So the ultimate exercise that we're doing now of trying to learn is really to recognize humbly that the textbooks of medicine have not been written, that we can still try to see patterns and learn things about medicine that haven't yet been outlined or described. And I think that's really what I'm trying to do here. I think I need tissue, and that's the only way that I'll believe that there's an answer unless something grows in a fluid. And I'm practicing now coming at this at different angles. And I'm coming at it like, what's my DDX for widespread bone lesions? And if somebody says to me widespread bone lesions, my first question is, where's the cancer? And it's interesting to me that the answer to that is not obvious. Because in most patients with widespread bone disease, they have a mass in their pancreas, a mass in their liver, a mass in their lungs. And it's so unusual that I immediately, like, nobody has a good answer for that. And then I asked myself, well, okay, is it really just bone lesions? But these seems to be bone lesions in such a weird pattern. They're so restricted in them affecting the axial spine, right? Like this patient really just has very central bone lesions. And so I'm just struck by how there's no good answer for where's the cancer, and struck by the geographic restriction to an unusual spread within the bone. It's very unusual to have a left femur lesion, I believe, with femur or tibia, it doesn't matter. One of those, either one is weird. And then rib lesion, like that's just such a weird pattern of spread. And then I think you're right, like when it's lung cancer, unless it's very unusual kind of lung cancer, there's no mass. And I think if I were to zero in on one other thing my mind is intrigued by is the airway predominance of the entry point, because I completely agree with you. This process seems like it began in the lungs. We got scattered nodules first, which now I'm wondering, were they scattered airway nodules? Then those nodules caused collapse of the middle lobe, further suggesting an airway issue. And now there seems to be a signature of some eosinophilic phenotype. And I think that when it's infection is fair game, cancers are fair game. But I think that the airway hypothesis, coupled with the unusual bone spread, coupled with him smoking, has me wondering whether he has a histiocytic disease. And so Langerhans cell histiocytosis is a disease that occurs almost always in people who smoke, that begins in their lungs and usually stays in their lungs, but sometimes can spread to the bones. And the interesting thing about that, it often causes tissue eosinophilia. The other name for this diagnosis is eosinophilic granuloma. That's what it's called in kids, because it usually causes just eosinophilia in the tissue, but sometimes can cause systemic eosinophilia. So now I'm immediate. Right? Remember we said earlier we won't know what's relevant or not. Now I'm really curious. How much did he actually smoke? Does he still smoke? Well, is the smoking just a small piece of his life, or was it a prominent part? So I'm curious, Sarah, if you know. I see it says former smoker. I didn't even register that earlier, honestly. But do you mind telling us, is that a prominent? Was that like, does he have a significant smoking history, or was it just a little bit?
I don't know if Jazz, if you found that, I don't think that we clarified that with him, or at least I didn't see that in the notes. So I apologize for that. That would have been really good for the history to obtain.
Oh, please don't apologize. There's literally out on left field here.
I'm not familiar with that either.
Professors, I think that's the best clue that we're not dealing with Langerhans cell histiocytosis here, is the smoking history is completely not relevant. But I just say that like the pattern is really interesting. It seems to be airways. The eosinophilias is weird. The pattern in bone spread is weird. I don't know what to make of it, but that thought crossed my mind. Any other thoughts that you've mulled over?
No, I just am like, I love that you brought up Langerhans cell histiocytosis. Shayma texted me about that possibility, and then I was like, oh, that's a great thought. And then I texted her back, Robbie's all over it. So thanks for commenting on it.
I'm honored to be aligned with Shayma always. All right, Sarah, you want to tell us more?
Sure. So this will start our 5th aliquot, it's pretty short. So the following workup was negative, including his blood cultures, TB antigen T cell stimulation test, Brucella antibody, and HIV. We talked to Palm, who was consulted for a bronch. We consulted IR for a left knee biopsy. And then the bone biopsy of his spine showed acute and chronic inflammation with focal giant cell granulomatous changes. He's still having increasing pain, and now he's on a PCA pump. And that is our 5th aliquot.
Robbie, is it me or you? I'm confused.
Raz, I have no idea.
I think, please, we started with math, let's end with math.
No, what geez. Oh, that's right. This is the end. Well, great. I'll start us off and then we get to end with your thoughts. Yeah, I think that I really appreciate the learning point that you made from the very beginning, which is that that we don't know if this is infection, what kind. Is it regular old that's hiding, or is it granulomatous? And I think now you have the word granuloma. And I think you made the earlier point that, well, I should say granuloma means atypical infection versus autoimmune disease versus cancer. And I think the only cancers that really cause granulomatous diseases are liquid tumors, which are less likely here because of the thrombocytosis, but Hodgkin's is totally fair game, and this could totally be Hodgkin's lymphoma. But I think when you hear the word granuloma, you got to really pursue the idea of an infection. The ultimate test of an infection is the histopathological culture. So we have to wait for this pathology. But I would say that whenever you have granuloma too, you have to think about sarcoid and histiocytosis. And there was an amazing NEJM case discussed by Gurpreet Dhaliwal, where a case of pulmonary sarcoid with aggressive spinal involvement was the ultimate diagnosis. So for me, I think I don't know what the answer is, but the path I would follow is, how rigorously can I exclude infections? How rigorously can I ask the pathologist to look for lymphoma cells? And if those are negative, and and everybody's saying, I promise you, we looked really hard, we can't tell, then I think for me, it's either wondering if this is all sarcoid or all a histiocytic disease. That's the path that I would take. Where we stop on this case, we find an infection, we find a cancer, or we don't find anything and land on sarcoidosis or a histiocytosis. I can't tell, honestly. What do you think?
I appropriately muted myself as I began to speak. I have zero to add. I'm right there with you. I can't wait to hear what happens.
Okay, so I can go into our final aliquot, number 6. So Pulm was consulted with the plan for a bronch with a BAL and to obtain possible biopsies if an airway lesion is identified. We talked to our good friends in the IR department for a left knee biopsy. They did not find any malignancy. It just showed reactive new bone formation / bone remodeling with marrow space and periosteum fibrosis and granulation tissue formation. We have our serum histoplasma antigen that came back positive, along with urine histoplasma antigen that also came back positive. And then our bronch was pending. Shortly after he was discharged so that he could be with his family. And after he was discharged, his bronch came back positive for blasto. So for the teaching point that I found really great for this case is the area along the Great Lakes is considered endemic for blasto. The lungs are the most common site of infection, followed by the skin, bones, and GU tract. It's also not uncommon to see disseminated blasto in an immunocompetent host, and it's in fact more common than disseminated histoplasmosis in an immunocompetent host. We learned that serologic testing is not useful for the diagnosis of blasto due to the cross-reactivity shared by endemic mycoses, most notably histoplasma. This was also just a fun reminder of med school. Beta-D-glucan levels are non-specific and can be elevated in histoplasmosis. However, blastomycosis does not have a cell wall with beta-D-glucan, thus values may be normal. Both acute and chronic blasto can often mimic other diseases, which you guys were nailing. Acute pulmonary blasto may be initially diagnosed as a community-acquired pneumonia or a viral pneumonia, whereas chronic pulmonary blasto is often thought to be malignancy or TB. And for the management, he was treated with itraconazole oral solution, which was preferred over the tablet formulation because of its greater bioavailability. And since he had disseminated blasto, duration of treatment was 12 months, and he required frequent monitoring of the itraconazole levels. And before I give it back to you all, you guys did an amazing job. I just want to give a special thanks to all of you, the clinical problem solvers team, as well as Jazz for making this happen. And most importantly, the fantastic Team A inpatient team that was led by our attending, Dr. Bogani, our rising R2s, Dr. MacArthur and Dr. Myers, and our soon to be graduated Dr. Bell. But thank you for letting me present.
I think both Prof. Rez and I are stunned in silence. What a thank you so much, Sarah. Prof.
Yeah, I also want to echo what Robbie said. This case was presented as a NEJM CPS. So congratulations to you, Sarah, and the CP Solvers team. Thank you for bringing it. And I just pulled up a NEJM article, which I'll share with you for waxing and waning pulmonary nodules. And that DDX is basically anything that causes pulmonary nodules. So it's not a helpful frame to have. I'm really excited for Bettina to do the teaching points. And thank you to our amazing scribes, Amanda and Yaz, or whoever else helped out. Thank you so much.
Reza, I'm going to take a play out of your book and interrupt for a second. I just want to quickly, first of all, thank you for having us present. And I think Dr. Lichtenstein did an amazing job presenting. For the University of Rochester folks that are on VMR today, I just want to really quickly put in a plug for the VMR. These happen Monday to Friday, sometimes even Saturdays. The entire clinical problem solving teams do a fantastic job of facilitating. After this is over, I'll send an email to the IM chiefs and also to the residents at FM to, if you want to be part of the live VMR, I think it's a great learning exercise. And last but not least, I don't think most know this, but rlrcpsolvers.com is a website that has been launched for almost a year now, and it's been a fantastic resource, up to date schemas and illness scripts that are not available on the regular website. And it is I think there is a cost to it, but CME does cover it. I just really want to encourage everyone to check out the website. I will also be handing out that link as well. So Bettina, you can continue. Sorry to interrupt.
It's okay, Jess. Thank you so much. It was just an incredible case, and we have a lot of learning points today. So I'll start us off with what Robbie said at the start, which is that among the data, what is actually profoundly helpful, there are data that are profoundly helpful or just relative noise, the latter of which we find that with more processing, it may not actually be noise, and it might actually be helpful for us. And that's something that is a recurring theme in our discussion today. In each aliquot, there are a lot of things that we considered, a lot of things that we revisited in the history, and that's a very important thing to note when we are dealing with our own patients. So we first talked about hemoptysis, which was one of the chief complaints of the patient, and that represents an abnormal connection between the vessel and the airway. So it's something that must not be ignored. And the chest CT can actually help us in narrowing down what causes this hemoptysis. So it can show us nodules, vascular issues like pulmonary embolism, cavitary lesions, and bronchiectasis. And then another finding that we encountered in our case is pulmonary nodules. And it can also have a lot of differentials. It can be central lobular, which can point us to aspiration. It could be perilymphatic, which could hint to sarcoidosis, or it can be scattered, which is what was presented in our case, which could suggest a hematogenic spread of infection or cancer, or something that is autoimmune like microscopic polyangiitis. So we also, when we talk about hematogenic spread, we also take note that we expect that there is proportional injury to other organs. And then Prof. Reza also mentioned the phantom nodules, or Rabi also mentioned about pseudo-hematogenic spread. And then in terms of spread, our diseases in general can spread in two ways. So usually through the vasculature via the blood or the lymphatics, or through contiguous extension. And we also understand the labs, look at the labs and understand why they exist. So it's a good mental exercise to do. And in our case, it really helped us narrow down our differentials. So looking at the CBC, the iron studies, the pleural studies, and especially the imaging, which could help us look into the different bone lesions that were present in our case. So in terms of the lesions on the spine, actually some infections have preferred locations in the spine. So for example, TB prefers the thoracic spine, and Brucella prefers the lumbar spine. Malignancy actually usually spares the intervertebral disc space because this structure is avascular. And when we talk about widespread bone lesions, it can also suggest a malignant cause. And then we also mentioned a little bit about necrosis, which is a destructive process that prevents blood flow to the tissue, which can hint to something invasive, like invasive infection or even cancer. And this is something that must be quickly addressed. We must quickly biopsy the lesion before it invades the spinal cord that can lead to neurological damage and would necessitate surgery for our patient. And then an important finding in our case is granuloma. And there are a lot of different causes of granuloma, but the three main chunks of it would be the atypical infections like TB or your fungal infections. It could be malignancy like lymphoma or Langerhans, and it can also be autoimmune. So, and then lastly, our final diagnosis was blastomycosis, and just a little teaching points for that. The Great Lakes are endemic, and then disseminated blastomycosis is actually more common in an immunocompetent host than disseminated histoplasmosis. And then treatment would include itraconazole. So those are our teaching points for today.
Thank you so much. Uncle Robbie, close us out.
Oh my gosh, dude. I just want you to know one thing. Bettina, what time is it there in the Philippines now?
It's 1:11 a.m.
Has anybody in the history of time delivered this ridiculous high quality teaching points at past 1 a.m.? Unbelievable. Thank you so much, Bettina, for jumping in last minute. And honestly, I hope that you guys just see the ridiculous amount of gratitude we have for everybody here. I was just texting Prof. Raz and I'm just sitting here thinking, how the heck did I get so lucky to be able to discuss with like one of the most wisest, kindest people in the history of the world, let alone like have guests from the University of Rochester come and present such an incredible case to us, who then spread the love to their team and their unit, and the incredible scribing that Amanda and Yaz did today. It's kind of surreal, to be honest, and to all the people who joined. It's
And the amazing energy that Reza brought.
yes. I started with Reza and I'll end with Reza, and the amazing Reza energy and the fact that he fills all my words. I don't even need to talk, but yeah, it almost beats hanging out with my newborn nephew, but almost. So I'm gonna go now. Have a wonderful rest of your Friday, and thanks everyone. Really appreciate you all.